Welcome everybody. My name is Dr. Guillermo Llamas. I am from Aguascalientes, Mexico. I am the director of the interventional cardiology department in the Hospital Cardiológico Aguascalientes. We are going today to be understanding hypertrophic cardiomyopathy, a new classification. That this new classification permit or help to you in the role of the diagnostics and understanding the management specific of each type of patient with hypertrophic cardiomyopathy. A long time ago, the cardiomyopathies was classified in different forms. Right now, the European Society of Cardiology and the American College of Cardiology decide to classify the cardiomyopathies in 5 different groups. The first is the hypertrophic cardiomyopathy, the second is dilatate, the third group is the arrhythmogenic right ventricular cardiomyopathy, and the fourth is the restrictive cardiomyopathy, and finally a new group in unclassified cardiomyopathies. But today we are speaking about the first group. The hypertrophic cardiomyopathy is very important because the prevalence is very frequently disease. And right now, we understand is secondary to genetic defects, and in a lot of patients the process is a genetic pathology. In the process of the classification, the hypertrophic cardiomyopathy was named for different names. Right now, I find 75 different names for the same disease, and finally, after of a lot of discussions and a lot of studies, the decision was to use the most common name, that is the hypertrophic cardiomyopathy, used right now in the most of the papers in the world. You can look in this diapo, in this image, the different names used in the last 50 years about this disease. But the historic evolution is very important, because if you remember, the more important presentation or the more important paper used for the diagnostic, the first diagnostics of this disease is attributed at Dr. Bramwell and Dr. Morrow. They present a group of patients with very important findings suggestive of stenosis, aortic stenosis, and this resistance of the left ventricular outflow tract was transitory and disappeared when the blood pressure was dropped. For this question, in these articles, the diagnostic or the name more used was idiopathic hypertrophic subaortic stenosis, but with the time this name was changed for the name that I told you previously. And in the history, a lot of articles was used for look for the possibility to find what is the etiology and the clinical characteristic and the physiologic characteristic of the disease. But with the time, a lot of these articles was necessary to retract it, because in the very important journals, these findings was very unusual and no was preserved in the time. The more important classification for the hypertrophic cardiomyopathy was made in 1981 for Dr. Maron. Dr. Maron used 125 patients with hypertrophic myocardiopathy diagnostic by echocardiography. When, if you remember, in 1981, the echocardiography started with the bidimensional mode, and with the help of this system, Dr. Maron have the possibility to find 4 different types of patients with hypertrophic myocardiopathy. But if you remember, in this time, it is only possible to evaluate clearly the alterations in the basal segment of the left ventricle. For this evaluation in the short axis, he decided to use the type 1, type 2, type 3, and type 4 kind of patients with this disease. But the most frequently was the type 3, is correspondent to patients with hypertrophic in the anterior segment of the septal wall and the free wall of the left ventricle hypertrophic segment in the basal segment. The second more frequently is the type 2 and correspond to patients with anterior and posterior segment of the septal wall, and the two less frequently is the type 1, 10% of the patients with hypertrophy only confined in the anterior portion of the septum. And the type 4 is in other regions different to the septal region basal, probably the posterior or anterior septum. So this classification was used for a long time, but was made in relation to findings related with the echocardiogram. A lot of studies made evaluation of this classification, and effectively the hypertrophic in the anterior septal and the anterior wall segment of the left ventricle was the more common segments with hypertrophy in this kind of patients. Is related with the type 3 Maron classification hypertrophy cardiomyopathy. In 1986, so 5 years after of this classification, the Maron classification was made, a group of doctors in Spain decided to use a new classification using the PTA, and they find through the use of this new system for evaluate all the wall of the left ventricle, and they find correctly that the type 3 classification of Maron was the most common, but they add 2 different types. The type 5 corresponded to patients with concentric hypertrophic, and type 6 corresponded to apical hypertrophy that was previously described for Yamaguchi. So after of the understand this article made for Carell and Rivera, and after Romero and Fariña using SPECT evaluate this visualization of the segments, they find these 6 types of classification. 6 types of morphological process related with the left ventricle in patients with hypertrophic myocardiopathy. The Mogues classification was suggested in 2013 for the use of these kind of patients, but usually this classification was accepted because it's very complex, and it's a classification very similar to the classification used for patients with cancer. But the Mogues classification in general is not used for evaluate this kind of patients. With the time, right now we understand the patients with hypertrophic myocardiopathy have usually 2 different forms in general. The first, the most common form, is patients with obstruction in the offload tract in the left ventricular segment, and is a patient with obstructive form. And a group of patients without obstruction. Is non-obstructive form of this disease. But it's important to remember only 40% of the patients with obstructive form have obstruction in arrest, and 30% of the patient that is named as latent obstruction in rest doesn't have obstruction and only is inducible by use of effort or one kind of drugs that increase the contraction or produce vasodilatation, like to maneuvers like to Valsalva maneuver or use of dobutamine in the evaluation of these patients. But if you understand this, you can look 70% of the patients have obstruction in the outflow tract, in the left ventricle in patients with hypertrophic cardiomyopathy. And 30% the obstruction is absent, independently of the use of maneuvers or use of drugs. 30% of the patients anytime develop obstruction in the outflow tract in the left ventricle. But other point that is important to remember is this obstruction is not only produced for the systolic anterior motion of the anterior valve of the mitral valve. And the other question is necessary to remember right now we understand a group of patients have obstruction in the right ventricle outflow tract. Is not only present obstruction in the left ventricle, it's possible to have patients with obstruction in the right ventricle. The mechanism and factors that is possible to produce obstruction in this kind of patient, in the patients with hypertrophic cardiomyopathy, is very, very different systems. Right now we can understand the most frequently production of the obstruction is the hypertrophic in the septal and basal segment, right? Producing obstruction during the systole of the outflow tract. But it's necessary to understand we have a lot of mechanisms like to anomalies in the papillar muscle, anomalies in the tendinous cords, and anomalies in the valves of the mitral valve, and other anomalies that is possible to produce alone or in combination produce obstruction in the outflow tract. The other point is, remember, the patients with hypertrophic myocardiopathy in the time develop a stage that can to produce different symptomatology, but Olivoto and Coles develop evaluation of the patients with hypertrophic myocardiopathy, and they find the patients with genotypic anomaly but non-phenotypic disease in the stage 1 is a patient without hypertrophic, without obstruction, and they are genetic with the disease, but is not with hypertrophic in the heart. The stage 2 is the patients that develop the classic phenotypic pattern. These kind of patients have hypertrophic anomalies in the left ventricle or in the right ventricle, but usually the systolic function is present and absolutely normal, and the most of the patients develop a hypercontractility phenomenon. So the usual ejection fraction of the left ventricle is more of 65%. But a long time evolution, it's possible to develop these two stages. The first stage, named stage 3 or adverse remodelation, is a patient with a little reduction in the ejection fraction, is not with hyperdynamic, apparently is normal, but for patients with hypertrophic myocardiopathy, this kind of patient have a little reduction in the ejection fraction, And finally, the stage 4 is named overdysfunction, or in some papers named burned out patients. This patient develop important reduction in the ejection fraction, usually less of 50%, and this patient have heart failure and usually have the possibility to develop dilatation of the left ventricle. So this way of the progression states of the hypertrophic is very important to understand when we are thinking in the possibility to make a classification for this kind of patients. Olivotto and Cole in 2012 described these four patterns, but in these patterns, when they speak about the stage 4, they find two different patients. Patient with dilated hypokinetic left ventricle, another kind of patients with restrictive pattern in the evolution. But finally, Melanisi and et al. In 2010 find other different patients with persistence of the obstruction, a little obstruction, but with dilatation of the left ventricle. So we can understand right now in this stage 4 of Olivotto, we can have three different patterns. The first is dilated hypokinetic, the second is persistent of the left ventricular outtract obstruction with dilatation, and finally restrictive pattern. These three patients are very common to find in the clinical evaluation. Other problem that we can find in patients with hypertrophic myocardiopathy, principally in patients with hypertrophic in the medioventricular segment of the left ventricle, or in the patients with apical pattern, like to Yamaguchi disease, the possibility to develop apical aneurysm. The apical aneurysm is anomaly is possibly to produce for the obstruction in the medial or apical segments through the presence of the ischemia in these segments of the apex of the left ventricle, and with the time is possible to produce aneurysm in the apical segment, but this aneurysm increase the risk of embolization and the arrhythmias and produce more risk of sudden death in this kind of patient. For this question, is very important to understand the patients with hypertrophic myocardiopathy have the possibility to have apical aneurysm, and we need to evaluate in all of these patients if this in each of these if they have apical aneurysm, because this anomaly is related with prevalence, clinical significance, and more risk of other complications. And finally, I need to speak about the presence or no of the right ventricular involvement in the hypertrophic cardiomyopathy, because usually we are thinking in the patients with hypertrophic disease, the develop of the hypertrophy is only locality in the left ventricle, and in a group of patients it's possible to find hypertrophic in the right ventricle, and in this kind of patient it's possible to have obstruction in the right ventricle. So the presence of the right ventricle is necessary to understand, because this kind of patients have two other complications too. So in 2009, Maron made a new process for evaluate the characteristic or morphological characteristic of the patients with hypertrophic myocardiopathy, and they made in 333 patients MRI with the necessity to understand what happened in the global segment of the left ventricle, because if you remember, the use of echocardiography bidimensional only permit to understand what happened in the basal segment, but the most of the patient is very difficult to evaluate all the left ventricle segment. If you use 4 apical chambers, it's possible to find more characteristics, but the use of MRI permit to understand clearest what is the anatomic findings in these ventricles, in the right and the left. Using this evaluation, Maron find the most common morphology was the basal hypertrophy, named sigmoidal hypertrophy cardiomyopathy, and the second one is the medial segment hypertrophic in the left ventricle, named reverse curve or medioventricular hypertrophic. 10% of the patient with apical, and the neutral is diffuse in 10%. But in this evaluation, they find a lot of patterns with different phenotypes, but don't make any evaluation for take the decision to make a new classification. For this question, we are offering these new proposals about the use and classification using the MRI and different systems for evaluate the morphology, phenotypical morphology of the patients with hypertrophic cardiomyopathy. We decide to use this 6-type classification. The first type is the correspond to the sigmoid basal hypertrophic, is the more common. Is the patient with basal, septal or anterior segment of the free wall of the left ventricle, but is basal. Usually this patient is the most common patients with obstruction in the outflow tract. 70% of these have obstruction. The type 2 is named mild ventricular or reverse curve, correspond to the 30 or 40% of the patients. The hypertrophic is in the medial segment of the left ventricle. Type 3 is the apical, or known like to Yamaguchi hypertrophic myocardiopathy. Type 4 is the neutral diffuse, is a patient with diffuse. Is very common finding in 10% of the patients. And finally, type 5 is correspond a patients with mixed. What is this? Is the presence in different segments, maybe basal, apical, or apical and medioventricular in different places, but is not diffuse. Is not diffuse hypertrophic symmetric. This is asymmetric with different planes or segments with hypertrophic. And final, type 6 correspond to these 3 different classifications in patients with dysfunction left ventricle offered by Olivotto, and correspond to patients with the type D is 6D, correspond to patients with dilated morphology. The O, type 6O, patients with persistence of the obstruction but with dilatation, and type 6R is this patient with dilatation with a restrictive pattern. And finally, we add the R letter in patients with involvement of the right ventricle in presence of this disease. So we can use this classification with different forms. We decide if the patient have type 1 and the patient is with obstruction, we add the letter O after the type 1. For example, in this type is type 1 O if the patient has obstruction. And if the patient have aneurysm, we can add the letter A. If the patient doesn't have obstruction, you can use the letter N, and you can use the capital R letter in patients with involvement the right ventricle in this kind of patients. Finally, I have 2 examples for this. In the first example is a patient with hypertrophic myocardiopathy in the medial segment and the basal, but have aneurysm, and this is type 2, is medioventricular. with aneurysm, the presence of aneurysm, are because the right ventricle is involved and is obstructed because have obstruction in the offload tract. And finally, this second example is about the patients with apical form. This is the Yamaguchi description, original description. It is type 3, but this patient have involved the right ventricle, is right ventricle involved, and is not obstructed because the hypertrophic is only in the apical segment and doesn't have aneurysm, and finally is slash and n about the non-obstructive. Thank you very much.